The main purpose of pre-anesthetic evaluation clinic, the specialty clinic. Patients are evaluated before surgery. So that earlier days we never used to have this sort of arrangement. So what we used to do is we just see the patient as they are wheeled in, and then if they are less than 40, I'm talking about 1975 when I joined the Department of Anesthesia at General Medical College. There was no protocol of making a pre-anesthetic evaluation. And they will send the list. Patient will be coming and sitting in the morning on the starved state, because surgeons used to tell them to starve from the previous night itself. So all of them will be sitting. We'll just go. If they are less than 40, no investigations. We'll just see the pulse, BP, make a cursory auscultation of the heart and lungs, and then say okay. Only when they are more than 40, we may check the BP and then ask them whether they are hypertensive, taking any medications. And if we think there may be a problem, at the most we may ask for an ECG, because that was the limited resources for any investigations in those days. And ask them whether they have any loose tooth or dentures, and whether they have a removable denture or not. So these are the primary questions that we used to ask, and then simply wheel the patient in and do the surgery. This produced a lot of problems that which we could not evaluate in the pre-anesthetic state, and many a times we used to land up with difficult intubations and cancellations, or other intraoperative complications used to happen. So to avoid that only, the concept of making a preoperative or pre-anesthetic evaluation proved that it could avoid a lot of morbidity as well as mortality. And the second thing is the medico-legal issue. When you just come, have a cursory look at the patient, and then go and do the surgery and give anesthesia, and if there is any complication, earlier days patients used to accept whatever you say, such and such complication happened, and they used to question the doctors. But after the advent of this consumer forum and consumer courts, people started asking questions: why this happened, what went wrong, whether it is anesthesia failure or whether it is a surgical mistake, and they started suing the doctors. So this also necessitated that you must make a thorough assessment of the patient, know the patient personally, explain the risk involved before you take up the patient, and try to develop a good rapport with the patient. So in case there is any intraoperative or postoperative complications, patient will be in a state to understand that the doctor has already told me that because I have high BP, there is a chance there could be some bleeding or some other cardiac problem which can result because my BP is not under good control, and this surgery is being a very emergency surgery, I have to accept the risk. All that has been told me. So patients will be in a mentally prepared state, and the relatives also will not be in a combative mood when something goes wrong. So that is another advantage of having a pre-anesthetic evaluation, either personally before the surgery or as a routine procedure in the pre-anesthetic evaluation clinic. So you can do the risk assessment and also make a decision about how to manage. For example, a diabetic patient whose blood sugar is 250 and he has a gallbladder which is threatening to be ruptured, which is acute polycystitis with a stone, and surgeon says we have to operate, otherwise he may develop a perforation of the gallbladder. So in that state, we cannot make him change the dosage of his oral medications and then wait for the blood sugar to come under control. We have to quickly make sure that he is not in a diabetic ketoacidotic state, control the blood sugar with rapid acting insulins, and then try to take him up as soon as possible, because the surgery is quasi-emergency or semi-urgent. So in that situation, preoperative management decision also can be taken up in the preoperative evaluation period. And what is the nature of this evaluation? It includes an interview. You talk to the patient, you ask them about their complaints, then examine the patient, make a review of all their previous medical records or any surgical and anesthesia problems. So by asking for previous surgical exposure, what are all the conditions you can find out? By asking especially for family history of any surgical exposure, what are all the major complications we can avoid?
Pseudocholinesterase deficiency,
Fantastic. It's choline apnea. If you don't have this pseudocholinesterase deficiency, the condition is called choline apnea. Any choline apnea in the family, very good. Any other familial condition?
Malignant hyperthermia.
Malignant hyperthermia, fantastic. That is the second important thing. Any other condition? Muscular disorders, okay? Duchenne's muscular dystrophy, especially patients with congenital cataract, they also sometimes have Duchenne's muscular dystrophy. So all this familial history you can find out, and the detailed account of current medication. As for rightly said, antihypertensives like ACE and ARBs. One question to the newcomers, either Ranjini or Kalpana or Anish Kumar or Arvind. Why she said, I think you all heard Shivasankari telling that patients should be asked to stop ACE and ARBs if they are taking it as an antihypertensive medication. What is the reason? Anjini or Anish, whoever wants to answer can answer this question. Have you learned the reason for this? By this time, all of you are more than 3 months in the specialty, isn't it? Are you all on? Ranjini and Anish Kumar, Arvind, Kalpana, are you all there? Or just logged in with your name and want to have a coffee? Okay, none of them are answering. Right. And provisions for reviewing preoperative tests. Pardon?
Good evening, sir. Kalpana.
Kalpana, what is the answer for why you want to stop ACE and ARBs before anesthesia and surgery?
They will cause rebound hypertension, sir.
Very good, fantastic. So it is sometimes they cause very severe hypertension, which is intractable or very difficult to treat. So in such situations, how do you manage? Supposing patient is having a BP of 150, 100, and he is taking telmisartan or AC inhibitor like lisinopril. How do you, when you stop the drug, the BP is likely to go up, isn't it? So
Yes, sir.
what alternate drug you have to prescribe in that situation?
We will prescribe calcium channel blocker.
Fantastic, very good, excellent. Right. So this is the reason for knowing the current medication. Like that, what anti-diabetic drugs you will ask the patient to stop?
All oral hypoglycemic agents will stop.
Supposing the surgery is in the afternoon and you permit light breakfast in the morning, so 6 hours ago, and will you accept, stop all the oral anti-diabetic drugs or selectively stop some drugs? This even the seniors can answer. Shivasankari,
SGLT2 inhibitors, sir.
SGLT2 inhibitors. Okay, that we have to stop. But supposing they are on metformin and
Metformin also we have to stop, sir.
Stop, sir.
Yeah, why metformin you have to stop?
It will lead to lactic acidosis.
Lactic acidosis. Very good. So these are all some of the questions that may be asked in the Viva. Okay, that is why I'm just asking all these things so that you will be familiar with the answer. And like that, long-acting drugs like glibenclamide and all those drugs can be also stopped because they may cause intraoperative hypoglycemia. And the common teaching in diabetic patients, it is better to err on the hyperglycemic side rather than on the hypoglycemic side. Okay? That is the reason why you have to know about all the current medications and this management. So the goals of PSC are create a rapport with the patient and their families, reduce the morbidity of surgery, increase the quality of patient care, reduce surgical delays and case cancellation. This is a very, very important thing. If you do not, if you have not seen the patient, especially in daycare, you just take the word of the surgeon that I have a hernia in a 60-year-old patient tomorrow. He is otherwise fit. The surgeon may say that because they don't go into the details of comorbidities and other things unless the surgeon has been a good patient-oriented surgeon who also has some interest in anesthesia. Many of the surgeons don't ask for the comorbidity. They think it is the duty of the anesthetist to take care of all those things. My job is only to operate and go away. So that attitude will be there in many surgeons. So in such patients, supposing you accept this word and go and find the patient as a BP of 180, 120 for a hernia surgery, you don't want to take the risk. And if I ask the patient and he says, yes, yes, I have been in hypertensive for 10 years. So you have not examined him properly. And you have to rule out all the target organ dysfunction. So in that situation, by just meeting the patient for the first time in the OT table may cause the morbidity problems. So you may sometimes have to cancel the cases also. The patient will be disappointed, OT time is lost, hospital time is wasted. So all these things can be avoided by a proper pre-anesthetic evaluation. And it decreases the cost of preoperative care also. Provide a centralized site for preoperative evaluation, decreases shuffling of patients who are mobile to multiple services. But if they are immobile, as I said earlier, with the fracture and pain, they cannot be brought to this situation. So this is for ambulant patients who can mobilize themselves. We can have them evaluated in a centralized place, and it can integrate various departments also, and including admission, registration, etc., and provide medical consultations for evaluation of complex comorbidities which are present in inpatient and patient. And you can have a strict protocol. You can have a printed format where you can get all the details printed so that anyone who happens to take up the case for the first time without seeing the patient, if they go through the printed protocols and the format of pre-anesthetic assessment along with all the results of the investigations, etc., it makes life easy for the anesthetist who has not seen the patient in the pre-anesthetic clinic but who is being posted to take up the case. It takes very little time for him to get oriented with the patient's conditions. And it produces maximize the efficiency in operating room function and turnover time because patients are already been evaluated. So these are all the goals and advantages of that. And it requires a multidisciplinary approach. Not only the anesthetist and anesthesia department are responsible, they should include all the other people like the surgeon, nursing, specialty, and hospital administration. And the location, the design is also another important point which we have to answer in your query. So it should be easily accessible from the main entrance of the hospital, and it should be preferably in the OPD so that you can have a, supposing you want a quick cardiology consult, you can immediately refer the patient to the cardiology room, which may be a third or fourth room in the OPD block. So it easily makes the other specialties get approached easily. And it should be preferably on the ground floor because especially for geriatric patients, you cannot have them climb up or come to the second or third floor like that. And it should have easy access to other diagnostic and other support facilities. And the design or the construction of the anesthetic evaluation clinic should have first a registration and reception area. Then it should have a patient interview and examination rooms, multiple rooms should be available. And there should be a counseling area where patient and family can be coached about it by a nursing staff or a social worker. And there should be a room for staff to take rest and adequate facility for toilets and the water and the other cafeteria like things, so that patient also can utilize it and staff also can utilize it if the working hours are long. And it should provide a relaxed and private atmosphere for the following activities: for by for review of all the medical records and history taking and examination, it should be have a spacious room, and discussion of risk and benefit and pain management strategies. Many patients are asking about, doctor, what about the pain? Last time I had a surgery, knee replacement in another hospital, and I was in severe pain. They did not take care of the pain. I could not walk for at least 10 days, and that resulted in some other problem. All those things, some patients may describe that. So you can tell them that I will be giving this block, or we will be making you comfortable with a particular medication which may be given as a intravenous infusion. All those things we can discuss with the patient, and the promise or the assurance that pain will be taken care of will motivate the patient, and their cooperation will be much better. They know that they are not going to suffer from severe post-op pain. And as I said, this is again a repetition of the point, allowing the anxiety, and telling about the fasting. In the, what medications you have to continue, especially thyroid medications, you will have to ask them to take it on the day of surgery. So the common question they will ask is, can I, you said the 6 hours I should not take anything. Can I take water while you're taking the tablet? Then you can definitely tell them you can take it with a sip of water at 6 o'clock in the morning if the surgery is in the morning time. And that is not a taboo, that you can have it with a sip of water. So, and sometimes you may have to give them, start the intravenous IV fluids during starvation time itself. For patients who are having diabetes or anything, you may have to give dextrose to prevent hypoglycemia. So all that can be told to the patient in the pre-anesthetic evaluation time itself, and the instructions can be given accordingly. And validation of consent and documentation is another thing. And reduction of day case surgery delay, or sometimes we can also communicate with the patient with a telephone call. Nowadays, WhatsApp and telephones are very mobile is very useful. So video calls and WhatsApp messaging and WhatsApp calls are very useful. So patient can communicate with you for any clarification, and you can also tell them if you have forgotten some instruction. You can always keep the number of the patient and communicate them before surgery. The staff requirement is a senior specialist should always be there, so that he can supervise. He cannot individually see every patient. He has to dedicate because volume will be high, so he has to dedicate the junior people. But he can have an overall supervision of all the uh, patients, how they are being assessed, and he will be in charge of policy administration and quality assurance. Then there will be medical officers or trainees and anesthesia should be posted as part of their training to ensure that they also learn how to do the pre-anesthetic evaluation. And once the assessment is given, it is valid for 2 to 30 days. Because sometimes beyond 30 days, you find that something may happen or change in the patient. But even though this period of 30 days is given, you must tell the patient that if you develop any other problem in between this period, because if you schedule a surgery 15 days after seeing the patient, you must tell them if you develop a cough or cold the 2 days prior to surgery, please communicate it to us, tell us what is the problem, and so that we can prescribe the medications to avoid any cancellation. Okay? So that with that information, if the patient's condition remains the same as you have seen 30 days ago, there is no need to do a repeat pre-anesthetic evaluation. You can go ahead and do the surgery with the same assessment that is done for them. So this is a very arbitrary value. This is not very strict guideline. But if the patient develops, for example, you assess the elderly patient for hernia, he is posted for surgery 3 weeks later. In between, he develops a chest pain and or an acute coronary syndrome. You are not going to take up that patient because you have already given the assessment. So this is an arbitrary thing for a stable patient with least comorbidities. You can always go ahead and do the surgery. And instead of wasting time on asking the patient about the detailed history and other things, nowadays we have specially designed questionnaire, especially in large volume pre-anesthetic evaluation clinic to safeguard the time. You can give the questionnaire, and educated patients can always fill up the questionnaire by saying yes or no, whether they have been asking and suffering from any ailments, whether what drugs they are taking. All these questions educated patients can fill up, or there should be a social worker or a junior nursing staff who can help the patient to fill up that questionnaire so that he can quickly get the required history and documentation of the medication that they are taking. And so this can be distributed in the waiting area where the patient is waiting, filled up with the help of relatives or staff nurse. And the algorithms for the evaluation clinic assess surgical risk, which is can be classified as mild, moderate, or high risk surgery. Assess the functional status, which is like ASA grade, or assess stability, shortness of breath, syncope, chest pain, leg swelling, paroxysmal nocturnal dyspnea. All these things should be evaluated. And if they have any problem with these three, then you have to have a referral so that you can get an opinion from cardiologist or a pulmonologist. All these things can be decided upon the patients giving the answer for the above questions. And the benefits of functioning are reduction in excess preoperative testing, reduction in subspecialty consult, especially if the anesthetist has got an interest in internal medicine, or he has already been a MD general medicine and then coming to anesthesia, then he can be a good physician, because anesthesia is always considered as a physician support for a surgeon. Okay? That is why we have to know more medicine than the regular other branch people. So anesthetist with an internal medicine training or a qualification or an interest will be a great asset to not only the pre-anesthetic evaluation, but also what the post-operative and ICU care setting. And you can have an enhanced operating room function. And daycare surgeries are being now done very frequently. So you have to keep with that. Assessment is done as an outpatient. For the sake of assessment, we don't admit any patients nowadays. So all the investigations are done as outpatient, and assessment is also done. And this is screening is done 1 to 30 days before. And the method of screening, patients coming from far off or even from abroad for surgery, people are now coming here because India is considered as a center for medical tourism. So the questionnaires can be sent to the patient and they can fill it up. You can have a telephonic interview. You can have an automated video call. So evaluation can be done in all these methods also without making the patient travel every time to the hospital for evaluation. And how is telemedicine technology used in PAC? What factors limit their use, routine use? So patients who have to travel, as I said earlier, for consultation, we use teleconferencing. Just like your con call, nowadays all of you are very familiar. When you make a conference call, you can include 2 or 3 patient persons also, and all of you can communicate. So in the same way, patient with comorbidities, supposing you want a cardiologist, you want a diabetologist in the same assessment time, you can have a teleconferencing, and all of them can communicate and make a thorough preoperative assessment. And the limiting factor for this particular is the cost. Not all can have a very sophisticated mobile phone or communication. So the common general public may not be able to afford this, and all the hospitals may not have the facility for doing this particular teleconferencing method of assessment. And the two drawbacks I told you about is not included in that. I have told that orally, but that also can be included in that as a limitations. One is that patients who cannot be mobilized to the
Please.
assessment clinic, they have to still be assessed at the bedside, number one. Number two, there will always be a different anesthetist who will be anesthetizing the patient from the anesthetist who has assessed the patient in the pre-anesthetic evaluation. And that is where the documentation is very important. So a regular questionnaire or a pro forma where you do the pre-anesthetic assessment, where you include all the factors like history, medications, airway assessment, lab investigations, like that, the pro forma will have all the columns. And if that is filled, cursory look at that will give the anesthetist who is going to anesthetize the patient a very good all the important information needed will be given to him from that pre-anesthetic chart which is attached to the patient. So that is the way to overcome these limitations. Okay? So that the 2 points you can add to this answer which are not specifically included in that.
Yes, sir.
Any doubts on that? Any questions you want to ask? Especially juniors, Kalpana or Ranjani, do you have any doubts about this?
No, sir.
Okay, right.